What is neurosyphilis? Syphilis is a sexually transmitted infection caused by the bacterium Treponema pallidum. Primary syphilis is a localized disease presenting with painless chancre, firm, non-itchy skin ulceration between 1 to 2 centimeters, and regional lymphadenopathy. Secondary syphilis is a disseminated disease with constitutional symptoms. It is presenting with maculopapular rash including palms and soles, condylomata lata, smooth, painless wart-like white lesions on genitals, lymphadenopathy, and patchy hair loss. Latent syphilis has no symptoms and can last for years. Tertiary syphilis is presenting with gummus, chronic granulomas, eartitis, vasa vasorum destruction, neurosyphilis, tabes dorsalis, general paresis, and Argyll pupil, constricts with accommodation but is not reactive to light. Tertiary syphilis disrupts the vasa vasorum of the aorta with consequent atrophy of vessel wall and dilation of aorta and valve ring. This can result in aneurysm of ascending aorta or aortic arch. Neurosyphilis is the infection of the central nervous system in a patient with syphilis. In the era of modern antibiotics, the majority of neurosyphilis cases have been reported in HIV-infected patients. Meningitis, the most common neurological presentation in early syphilis. Tertiary syphilis symptoms are exclusively neurosyphilis, though neurosyphilis may occur at any stage of infection. A 44-year-old man comes to the office due to several weeks of difficulty walking and frequent falls. He has had no headache or visual impairment but reports episodes of sharp, stabbing pain in his extremities. The patient has HIV acquired from unprotected sexual contact and is non-adherent with treatments. Temperature is 37 degrees. Neurologic examination shows 5/5 motor power in all extremities. Deep-tendon reflexes are absent at the knee and ankle bilaterally. Proprioception and vibration sensation are reduced throughout the lower extremities. He has a wide base gait and a positive Romberg sign. Which of the following diagnostic findings is most likely associated with this patient's current symptoms? The correct answer is E. Reactive VDRL tests on cerebrospinal fluid samples. This patient's sensory ataxia and lancinating pains raises suspicion for tabes dorsalis, a late form of neurosyphilis that usually manifests several years or decades after initial infection with Treponema pallidum. Tabes dorsalis is characterized by a slow degeneration of nerve fibers in the dorsal column of the spinal cord and dorsal nerve roots, which leads to diminished vibratory, proprioception, and discriminative touch sensation. Common manifestations include sensory ataxia, wide base gait, and loss of equilibrium when the patient's eyes are closed, positive Romberg sign, due to damaged lower extremity proprioception. Absent deep tendon reflexes, due to damaged dorsal nerve roots. Lancinating pains, sharp, stabbing pains that may last minutes or hours, the exact cause is unclear. Spirochetal damage to the midbrain tectum also commonly results in Argyll Robertson pupil. This finding is marked by small, irregularly shaped pupils that fail to constrict to light, but that constrict normally to accommodation, light near dissociation. Most patients with tertiary syphilis will have a positive VDRL and mild lymphocytic plesiosis on cerebrospinal fluid analysis. Summary of tabes dorsalis. Epidemiology. Tabes dorsalis occurs years to decades after initial infection. Tabes dorsalis has increased incidence and more rapid progression in those with HIV. Pathogenesis. Treponema pallidum directly damages dorsal sensory roots. It leads to secondary degeneration of the dorsal columns. Clinical findings. Sensory ataxia. Lancinating pains. Neurogenic urinary incontinence. Associated with Argyll Robertson pupils. Treatment. 10 to 14 days of intravenous penicillin G. Choice A. Central nervous system infection with Mycobacterium tuberculosis and acid-fast bacillus is usually characterized by headache, vomiting, cranial nerve deficits, and confusion. Lancinating pains and altered lower extremity sensation would be atypical. Choice B. Herpes simplex encephalitis primarily affects the temporal lobe and causes fever, headache, impaired consciousness, and seizures. Choice C. Cryptococcal meningitis can be diagnosed by examining the cerebrospinal fluid for encapsulated yeasts using India ink. However, cryptococcal meningitis usually manifests with fever, malaise, and headache. Lancinating pains absent deep tendon reflexes, and altered sensation would be atypical. Choice D. JC virus is a polyomyrus that replicates in oligodendrocytes, glial cells. Reactivation of JC virus causes progressive multifocal leukoencephalopathy, which occurs primarily in severely immunocompromised patients, for example, AIDS, lymphoma, leukemia, and causes progressive dementia, motor deficits, and visual impairment. Choice F. Patients with untreated HIV are at high risk for cerebral toxoplasmosis, which usually manifests with headache, confusion, fever, and focal neurologic deficits. MRI of the brain usually reveals ring-enhancing lesions. Educational objective. Tabes dorsalis, a late form of neurosyphilis, causes progressive degeneration of the dorsal columns and dorsal roots of the spinal cord. Manifestations include loss of proprioception and vibratory sensation, severe lancinating pains and sensory ataxia, for example, wide-based gait, positive Romberg sign. Many patients also have Argyll Robertson pupils.